My name's Sue. I'm a paediatric practice educator in Mid and South Essex Trust. I'm actually just about to be rolling out the national pews, and my question is for Emma, because there was you discussed about the sepsis tool right at the very beginning, and that's one of the things we have major issues with, Emma, because we're currently on the peer sepsis tool and have been for 3 years, and we've been on a QI project to make massive changes. And we've been asked to move to the Sepsis Trust National Pews sepsis tool, which is quite different. I think you probably would agree. It's very, nondescript. And yes, I've got 5 weeks left to go, and it's quite a challenge. We're moving from local pews to national pews and Sepsis Trust tool. So I'm just wondering if you have any suggestions.
I absolutely agree with you. That's a lot of change in one go. Yes. I'll be blunt, I'd just go with the national pews. Because I think that the tools and the sepsis, I didn't include it this time round, but we know from some work we've done in London that if you use the Sepsis Trust tool to recognise sepsis, it will trigger 40% of the children who walk through the door. Yep. And that's really unhelpful. And then you lose trust and everybody starts getting fed up because everybody is triggering. So I just think use your pews, because actually that fits with the AOMRC, and then use that as your trigger instead.
I will take that information back. We've this is a CQC recommendation.
There is a so the CQC recommendation was that you should use a tool. However, Damien Rowland has discussed it with them, and there's a little paragraph hidden away in the middle that says if you're using pews, you don't need to use the training tool, and I can give that to you. So please. There is an out.
Okay, thank you.
And I think it's a very good point around policy and guidance, right? It's if there is something else that you are using that is evidence-based, as even the NICE, Peter from NICE said, it's a guidance, it's a guideline, it's policy, but your clinical judgment and your setting also matter in these decisions.
Hello, my question's for Emma as well. My name's Peter. I'm a CCOT charge nurse from the Royal Derby Hospital. Hello.
Hello.
My concern is with the Martha's Rule. I am, by training, an adult nurse. As you rightly say, paediatric sepsis is very hard to do. We are now being pushed towards the idea of us being the Martha's Rule phone call. If you have a family who's not being listened to within a trust, is really somebody without any expertise within the paediatric field the appropriate person to be on the end of a Martha's Rule phone line?
This is a great question, because this is about resource and who. So I think the Martha's Rule was set up in mind, assuming that everybody had a critical care outreach team and that everybody had an expert on hand. And it didn't come with resource to make the experts. So I think all our district general hospitals around us are in the same position as you. And we've had a lot of discussion about this. Even within our hospital, PICU didn't want to answer our calls because they said it would be too much work on them. And I think, so in our experience, what we did is we supported PICU and we said, actually, we're going to do all this work. And if we do this bit well, you won't get many calls. So if we talk to parents, if we embed it in our pews, if we make sure that we're constantly doing these things, actually you won't get many calls. And that has turned out to be true. So you need the bottom bit supported. From the top down, our district generals sometimes use our Nectar transfer service. So that's been quite helpful. And then they've embedded the same kind of advice and guidance so that it gives you an outside. They won't necessarily come, but they can certainly do things over the phone. And we do hold conference calls. So they might hold a conference call with a Nectar transport team, the PICU, maybe a specialty consultant, maybe, for example, a neurosurgeon and the district general team. And that has been good, because I think it's about who supports you. But yeah, it's a really big problem.
How have you found the process of sharing in these sorts of settings, where there either in small groups with healthcare professionals or researchers. What has been your experience?
Do you know, to start off with, I'm moving it down, Angus, I'm still short. Very short. Initially, I think going through the story, and when I wrote that complaint to the CEO, it was a long letter. And initially, it broke me. In fact, I sent the complaint and I was off work for a while because my mood was so low and I just couldn't pull myself out of it until I met, obviously, the patient experience team. And then she made me do this Life Lens thing for Winchester University. And it's kept on their records. I'm like, oh, God, that's me on a camera and I hate it. But it was the beginning of hearing that when you share a story, that it lives and it impacts people. So when I was going through my maternity training, when we did baby loss, we had actual parents and families who'd lost their babies. And that's the one training that really has stuck with me because it was real and it was them. So how could I stand there and be frightened of sharing my story because I'm uncomfortable in my skin and I hate standing up in front of people when I have the opportunity to something good to come out of this? So yeah, at the beginning it was really tough. Keep going over it was quite tough. Now I don't feel negative afterwards. I'm like, I've done it. One, I've stood here, and two, I might well stop somebody from just ticking a VIP form to say a cannula looks okay when actually you haven't even checked it because we've got an audit lady coming along and want to make sure everything's ticked. So that's the difference.
I think that's really helpful. I think for me, I'm a pharmacist and I was working in a hospital as an antimicrobial pharmacist and then I went into a national role. But what changed for me, where I always say tackling antimicrobial resistance became more than a job, was because I heard a patient's story. It was because I watched a little girl. It was in those days, it was 2010. In those days, there wasn't much out there. You couldn't easily find information, but I saw the story of a girl who had a tiny scratch, ended up in hospital, 5 months later, double lung transplant, wheelchair, and I kind of followed her journey over time. And she sadly died just a couple of years ago in her 20s, but for me, that's when it changed. It was literally a patient story, somebody that I would never meet. I'd never met her, don't know her, but more so when we have someone live with us. And I think, sometimes when we're doing our work, it feels like just a job, but it's the patient. And what really got to me was that could be my children, God forbid. But, that's what I was thinking, is that they could just be playing and something could happen. So, and with sepsis, again, I'll just share, it's the national guidelines that come out. It could be any of us. It could be our family members. And I think this is really important that we continue to hear those stories to remind ourselves in the midst of the busyness of life and in the stressfulness of working in the NHS as well.
Hi, I'm Millie. I'm from Hull, and I actually work in paediatrics. So I'm currently trying to implement Martha's Rule. You'd mentioned in your story that you wish that yourself and your family had been listened to.
Yeah.
What do you think would have been different in your outcome if they had been listened to and if Martha's Rule had been implemented at the time?
When I had to make my presentation much smaller. Thanks, Millie, for the question. If Martha's Rule had been in place, then my mum wouldn't have got to the point where she begged a nurse. And when I say begged, she begged the nurse. And it wasn't till then that someone finally listened. We talked to the consultants, our experts, but they're not the expert in the individual. But we spoke to the consultant and he was really blasé. Oh no, she'll be fine, she just needs to eat. Well, you can't when you've got 3 areas of obstruction in your bowel, but because nothing ticked his boxes and there was a diagnosis bias that obviously was handed over as well, this is going on. I even just imagine people in a handover room saying, oh, and she's a midwife. And everyone goes, that's why, because they're pains. There's probably nothing wrong. But actually, some of us are like me, and I tend not to try and be difficult because you want to put across that you're an easy person and not just a typical midwife. But no matter where we went with things, there was this brick wall. And if we'd had Martha's Rule in place at that point, if we had call for concern, my family and my husband and my mum just did so much going back and forth. They would have had a chance to say something isn't right. No one's listening. But actually, the other person it would have really helped would have been the healthcare assistant who knew me because she did all the care. She was doing my NG tubes or my cannulas or my catheter side of things. She knew me and my family. But I was saying before when I was talking to a lovely gentleman, I said, sometimes it's the people with the least authority that have the most to give as far as what's going on with a patient. So Martha's Rule would have allowed even her to go beyond putting a sticker in the notes and saying, this isn't okay, I've escalated it. And then you've got one person saying, oh no, she's stabilised now. I was quite young. And we like babies, not to the extreme of babies, but we do compensate and then fall off a cliff, which is what I did. But they didn't listen on the way. So I believe that it would have given mum a tool, someone to talk to say, can you give someone a fresh set of eyes to look at this? Something isn't right. I had things in my notes that said, make sure you're not treating anxiety with opiates, because I was on my PCA. It wasn't anxiety. It was 3 areas of my bowel that were dying off because they couldn't see it in scans, so therefore it was my fault and I was making it up. So these are the little things that make it worthwhile. And yes, Martha's Rule, the call for concern can make a difference for all of us, whether we're clinicians or not, or whether we're housekeepers even, that have come along and said, I've noticed a difference, but no one's listening, and give a call. So yeah.
I guess the question then is Martha's Rule has everyone been empowered? Are the housekeepers, are the healthcare assistants being empowered to know about Martha's Law and then know how to implement it? Don't have to answer the question. Somebody's got their hand up at the back.
Oh, I'm so glad I'm not the runner. That's a long way.
Hi.
Hi.
As part of the outreach team in East Kent, we do the beach training. We actually speak to the HCAs, and we really emphasise about how they do all the care, and actually they're the ones that are there that'll see you the whole time, and how to escalate and not to let
Brilliant.
doctors and nurses that aren't listening to them, not to let them stop that from escalating, and to be able to call us ourselves. So they are kind of empowered, I think, where we
That's
are.
brilliant, but it's
with
not
our
the case
teaching.
everywhere, unfortunately. So
Wow.
can we all do
We could
that?
do a poll, right? But we're not going to.
No.
But
It's a whole nother
hopefully-
talk.
Sorry, carry on. Oh, yeah. Take 2 more questions and then we can move on. Thank you.
Thank you very much, Becky.
Hi.
My name's Lee Chin. I'm one of the microbiologists in Gloucester. So my question to you was about what would ideal post-discharge support look like? Because I know we don't even tell people they've had sepsis, but having even been admitted to intensive care for that amount of time and the whole life-changing effects took presumably a great psychological toll, which you hinted at, and I don't know what we would ideally be doing to support our patients.
You probably wouldn't have a patient like me that discharged themselves from ICU. That's the midwife in me. I'd had enough, and my mood was so low that I'd literally had enough. I didn't self-discharge. I had everyone's okay first, otherwise my mother wouldn't allow me home. But the thing we need, because I actually did leave the hospital with nothing, no TTOs, bearing in mind that Clexane alone would have been great when you've got platelet levels that are ridiculously high. So I had no TTOs, I had no physio input prepared, I had no community nursing bits prepared, and I had nothing to help me move around. I couldn't walk without a frame. So when I got home, thankfully, because I know what we need, I called all these people. And I said, I need this put in, but what if you're someone who doesn't understand how it is, and then you go home, like me, without people to advocate for you, without knowing what you should have? Does that person end up with a blood clot and die because they didn't know? Or, like antiemetics, simple stuff that stopped you feeling frightened, because I hate being sick. I was not eating. So for me, I would say to think when you are discharging someone from wherever, what is this going to look like when they go home? But more so, duty of candour. Just be honest. Because if someone had just said sorry to me then, I wouldn't have felt so angry at 5 years. But everyone had avoided saying it. We knew what happened. We knew where it came from. It was a lovely microbiologist. His name was Dr. Diath. Can't forget that, because it literally is death, isn't it? Let's be fair. But he saved my life. And he was the one that said it came from the cannula. That's where it was isolated from. So when you're discharging someone, what is it going to be like for that person when they go? Could we give them a leaflet from the UK Sepsis Trust? It should be routine, but it's not. So maybe introducing that could really help.
Thank you. I can't see any other... Oh, okay.
Tell them they can email.
There were no questions, right?
I know. This is your fault.
Bex, I'm Shelley. I'm a clinical educator from County Durham. Thank you for sharing your story. It was really powerful. And I wonder if I could ask you, as a sepsis survivor and a mum, I'm currently in the process of adapting some leaflets so that when our parents are discharged with children who have had sepsis or we've started treatment for sepsis, we've got something to give them to say, this is what, you've heard this word and this is what it might mean and this is it. But as a mum, it was something that your son said really struck me, that his dad had really protected him.
Yeah.
So how much is too much and what's enough, I think is...
Yes, this is a good question. See, me, my kids hear everything. I do a brilliant sex talk. It's amazing. Makes you cringe as a teenager. But no, I think John did do what was right. He just moved in, he was in senior school, he was struggling at the beginning, and we were exceptionally close. So he's my boy. He's actually a mummy's boy. Might be a big grown-up 20-year-old, but he's mine. And so John did keep it. So I think we can be honest with our kids enough to say, you've been quite poorly. Used very, very poorly for a child. Sepsis doesn't mean anything to them. But say, you may well feel tired. Tell them the little things, because then when they're recovering, they're not feeling like they're still ill, they are recovering. You're going to be tired. You might not be able to run the way you used to, but you will get better. And these people will let you know, can you let me know, this is to a child, whether it's making you breathless or you feel sleepy, tired again. As a parent, we need to be a bit more honest with parents. We need to empower them. They need to know what sepsis is and what can happen. Otherwise, how are they going to know? I knew what sepsis was. I've had it 3 times. And every time I've not recognised it in myself, and I teach this. Great. However, my mother does. I did recognise yours though, didn't I, Ma? Kept her alive, that's all good. But yeah, so be honest with the parents, because we cannot expect them to make the right decisions if we're not telling them the whole truth. They don't need to know about each little microbe that's causing a problem, but they do need to know what to expect and when to come back in. So honesty is key for everyone. Thank you.
I'm going to take one final question and then we'll move on.
It's more of a thank you for doing your story, because it's amazing that you stood up there and had that courage. I'm a sepsis survivor myself, and I got missed myself. I had a health visitor that told me that I was anemic and I was breathless because I was anemic and I was breastfeeding and I was imagining it.
Obviously.
A GP told me it was a viral infection to keep taking the Nurofen. And I also had a physiotherapist that said picking up the baby carriage was the reason why my kidneys were hurting when I was in kidney failure.
Yeah.
And it was the 4th doctor that said, call an ambulance, she's not going to make it. So it goes back to the community as well. So it's not just in hospital, it's people in the community that are not listening.
No, they're not.
And there's no way of escalating it. And this was 24 years ago. And I can remember all of the hallucinations as clear as day. And I too do teaching. So it's a powerful message and it does work. I've made her cry with the story.
I know, you might make me cry. Mum was hallucinating butterflies when she was in the hospital, but she didn't want to be there because of COVID. And I was like, you have to go, you're unwell. But she didn't tell them about the butterflies because she said it might sound like she'd lost the plot. It's all good. Thank you, everyone, for getting engaged, and thank you for listening.